We will be starting the session today. I would like to welcome you all to our session on contextualizing medical education for conflict realities. It is my pleasure to welcome Dr. Ghassan Abu Sitta, the chair and the director of the conflict medicine program at AUB and at the Global Health Institute. We also have with us today Dr. Mansoor Khan, who is a professor of surgery at Brighton and Sussex Medical School, and also a visiting professor at Imperial College. Dr. Mansoor is also a general trauma consultant surgeon. So we are very happy to have you with us today. So before I leave the floor to you, I would like to first start with a very brief introduction to give a little bit of background on the topic and to also highlight some of the work that we do at the conflict medicine program as part of contextualizing or embedding conflict-related health training into medical curricula. So to start with, we all know that we have been enduring so many conflicts in our region, specifically the MENA region, from Lebanon to Iraq to Palestine, Syria, Yemen, and beyond. And all of these conflicts or armed conflicts create an ecology of war, as Dr. Ghassan would say, where the challenges or the problems that arise do not end with the end of war, or do not end with the ceasefire. And so, of course, these conflicts would have a devastating impacts on communities, and they would place an enormous strain on health systems and a persistent healthcare burden, where professionals or healthcare professionals are expected to respond or to be prepared to respond to these challenges, whereas at the schools or at the universities, they are not being uniquely prepared to face these challenges. And this is what makes today's discussion very important. So if you want to prepare the next generation of healthcare professionals to work effectively in such settings, it's important to prepare them from the start. So as we know, today, most medical curricula in the Global South is based on models that were developed in the Global North. And while these models are very valuable, they don't always reflect the needs of the local people. And with that in mind, the conflict medicine program at the Global Health Institute has established or has been working on developing some initiatives that work on integrating conflict-related health education into our curricula. So starting with the Center for Research and Education in the Ecology of War, or CREW. So this program is basically a fellowship program that was developed with the aim of enhancing the research and the capacity of frontline healthcare practitioners. So this program is a one-year mentored fellowship program that we have been doing since almost 6 years now. We have so far graduated 3 cohorts from different countries in the region, conflict countries, including Lebanon, Jordan, Afghanistan, Syria, Iraq, Palestine, Yemen, and Sudan. Our other program is the Certificate in Conflict Medicine, which is an online certificate that also aims to deliver medical knowledge that is contextualized to the settings of conflict. In the CCM, we have 3 core courses that form part of the certificate and a specialization course that includes war wounds, infectious diseases, and cancer and conflict. So for the certificate, we have already piloted it in 3 different conflict countries, namely Iraq, Yemen, and Palestine. And so far, we have over 400 enrollments in this certificate. Recently, also, we hosted a regional dialogue on the need or on the importance of integrating conflict-related training. So this dialogue or this event has been attended by over 200 international healthcare practitioners, academics, and humanitarian actors from across the MENA region. And what resulted, or the recommendations that came out from these events on how to integrate conflict-related training into healthcare curricula have been recently published in a position paper that highlights these key insights and these key considerations. Also, more recently, we have been working on some case series that aim to strengthen the preparedness of healthcare practitioners in high-pressure, low-resource environments by simulating real-life scenarios that mirror the complexities of healthcare delivery in conflict zones, And lastly, we have also been recently working on a fellowship program that is designed to provide mentorship, field opportunities, and competencies essential for surgeons in conflict settings. So in a nutshell, this is what the conflict medicine program has been working on with Dr. Ghassan Abu Sitta. And I would like now to leave the floor to you for to take on with this discussion. So I'll stop sharing and leave it to you, Dr. Ghassan.
Thank you very much, Tracy, for organizing this meeting. And thank you, Mansour, for agreeing to speak in your very busy schedule. For me, this conversation I've been wanting to have with Mansour for a long time. Professor Khan occupies a really unique position where he brings an experience from the regimented, protocol-led medical Army Corps as Surgeon General in the Royal Navy. He brings the academic rigor from his professorial position in the UK, and as a practicing surgeon in the Global South and the Global North. I really wanted to see how he views this gaping hole in medical education in the Global South, where students are still fed those curricula designed to treat literally first world disease loads, and in the Global North, where increasingly students, junior doctors, view their commitment to humanitarian medicine as a critical part of their career. And therefore, we wanted to start discussing with Professor Khan what were the lessons that he has learned from his experience in the military that he feels need to be brought, so that we start graduating health professionals that are able to deal with this disease load that is unfortunately endemic in our region.
Thanks,
Mansour?
Thank you. That was quite an extensive question, and lovely to be put on the spot with this. First of all, thank you for the opportunity to speak here. And actually, as you said, this is an extremely important topic. Now, if I go right back to the basics, disease, misery, and suffering are absolutely everywhere. And the basis of your question is, how do we train individuals so they can get the skill set to deliver healthcare in these environments? So I think it's twofold. You need the skill set to deliver the care that you're providing, but the environment you're in, which can be very, very different. Now, if I tackle the first part about how do you train for the Global South, and remember, it's a two-way street. There are problems with the Global South. There's problems with the Global North. There are disease processes in the Global South we don't teach about in the North, and vice versa. So my fundamental thing is, regardless of whatever you want to do, you have to have the basics ironed out well. Individuals ask me, how do you manage to be a trauma surgeon? How can you open up the chest? Well, I've got to be good at being able to operate, first of all, in elective procedures, know how to use the equipment, know how to suture, know how to, work in a team, work to optimize patient care. And only once you've got the elective practices, and I'm going to talk about general surgery, hernias, a right, a left hemicolectomy, exposing the aorta. Once you can do that in an elective environment, and your mind map has been made that you can do this in an elective environment, then you can go to the emergency environment where the time is less and you have to make the decisions quicker. And then you go into the trauma, the exsanguinating environment, where you're in even higher intensity. Now, I'm going to put that as one Lego block. So you've got this way to and it's now 8 people in the global north who do operate in trauma systems in an environment where they're in that environment. To conflict zones after the patient, you then have the inherent risk to life. Now, how do you get somebody all together to be able to do that? I'm going to bounce that back to you, Ghassan. What do you think about that framing of that? Does that kind of make sense? What I've just kind of suggested along that framework?
Absolutely. But my question to you is this. How early do you introduce in the medical education process these ideas? You were describing the most extreme scenarios, but you and I have unfortunately seen situations where accomplished trauma surgeons who have spent their life dealing with civilian trauma mismanage blast injury wounds, mismanage high velocity military gunshot wounds, because they just think that this is just an extension of a road traffic accident or an extension of a civilian penetrating injury. And so the question is, do you instill these basic principles, as you do with other basic principles from undergraduate, or do you keep this to a postgraduate level?
I think the world, I think the world, if you look at, be amazed what's happening in medicine world. It's silo. There are 2 aspects to seasoned surgeons doing what they do. And I'm going to break them down into 2 aspects. One is hubris. I know what I'm doing. You cannot possibly tell me how to change it because this is how I've done. And I've witnessed this myself. The second aspect is, you know what? When you are caught in blast environment and you've got that shock phenomenon, humans go back to what we're comfortable with. And if what we're comfortable with is doing our elective routine care, that's what will go into our mind. Okay, I've got this wound here. I'm going to forget it's too long. Cough gone in there. I'm just going to everything else looks okay under. I don't need to floss the wound or potentially lay it open. It will be fine because it's how it goes. But then you have the other extreme. You have the individuals who have been exposed so much that unfortunately this becomes routine to them. They start undertaking routine war zone practice, but they don't treat the actual patient for their individual injury. Does that kind of make sense? So given those 3 kind of paradigms, yeah, it's a really messy and a massive situation because, like yourself, when we have had post-operational reviews, even though we know the environment, we can envisage it, it's not 100%. We can put ourselves in the position of that surgeon when they were operating. You never know what loss they have. Did they just lose a really close friend? Have they? All it takes is fractional changes in mindset and decision-making for outcomes to change. So it's a really complex dynamic. But what we can do to mitigate this is actually explain what we are doing now as discussing like this at an earlier stage to students, that medicine is dynamic. Emotional and medical responses to injury are dynamic. You cannot be an automaton and do the same thing over and over again because you may not be clinically, skillfully, emotionally be able to deliver that. The patients themselves will change. I think the worst outcomes I've probably seen is when people stick to textbook practices of how to deal with a certain wound and they do not manage the patient. You as a plastic surgeon, you can turn around and go, why the devil did you do that? You've totally scarred this person. It wasn't required. But how do you get that expertise? And as you know as well as I do, Gus, is the more you go to war zones, okay, the more it is playing Russian roulette. So unfortunately, the more experienced you get, it's that like experience and life expectancy are like that in conflict zones. I'm afraid that's the way it is. The more you go, the more valuable you become.
Dr. Ghassan, you're muted.
With regards to your previous experience as a surgeon commander, how did you deal with what now the humanitarian sector is struggling to deal with, which is that continuous march towards early super specialization? You know, the days when organizations like ICRC or MSF could find the general surgeon who could do the hysterectomy and the laparotomy and manage to safely do a burr hole and maybe put some external fixators is gone. The day that that those people who trained you at the beginning of your career, the general surgeons, who were general surgeons, as opposed to breast surgeons or hepatobiliary surgeons or colorectal surgeons, is gone. And so how did you manage to unify a basic set of skills and knowledge in an ever-increasing surgical world? And the same applies into orthopedic surgery. You know, you have the hand surgeon and the hip surgeon and the knee surgeon and the shoulder surgeon, and you no longer have a generalized training.
Yeah, no, great question. And I think fundamentally here is it's driven by the health economic demand of the country you're in. So if there is a push to get patients seen, you've got the super specialization, which allows individuals to focus on this. And then I'll be honest with you, with the super specialization comes income, comes private practice. And that may be a driver for a lot of people: lifestyle, income, private practice. You know what? It's the people's personal choice. I'm not here to judge, but that's what happened. What you will find is people who are interested in conflict, general humanitarian surgery will go out of their way to increase. I used to go to orthopedic lists. I used to go to neurosurgery. I could do a C-section because, as you're well aware, the first thing that happens in a major humanitarian disaster is anybody who's peripartum ends up literally having a C-section going into delivery. So, yeah, I think this is driven by the country you train in, the health limit on all that. If you have a personal desire to do this, and I know because I've trained a lot of these people will go out of their way to increase their skill set. But further to your point, there is very, very little point in somebody who is not familiar with humanitarian or an austere surgery saying, I'm doing a general surgery on call, I can go to a war zone. I'm sorry, your general surgery on call is an appendix, a strangulated hernia, maybe a laparotomy. What are you going to do about the person who comes in with a massive burn? What are you going to do with the ocular injury that comes in? What are you going to be doing with a pediatric patient who comes in who requires some kind of pediatric? The medicine is absolutely vast. And it goes back to when we first deployed as juniors, is when somebody, a house officer used to turn around and say, I want to deploy to a war zone. And you'd be like going, what, without sounding really harsh, what are you going to do? It's a risky environment. What do you bring to the party, which a senior medic, a senior combat medic, a senior nurse doesn't bring, okay? Go ahead, specialize, bring a skill set to this environment which is lacking. And I think that is what we need to address the younger folk is it may seem, or anybody, it may seem like a really good idea. Oh, I'm going to be blunt here. I'm a trauma surgeon. I don't care if you're a trauma surgeon. There's a big difference between being a trauma surgeon and being somebody who's deployed to a conflict zone and operated in that environment. If so, you need to have the right mindset with the relevant skill set. And as I say, the deploying skill set for somebody to go to a conflict zone, war zone, is massive. And the only way to maintain that is A, you either deploy lots, but if you deploy a lot, what happens is you get elective or emergency surgical advancement fade. Unless you go back into that environment in your hospitals, you necessarily don't get the relevant CPD to progress. So I'm not saying become a career conflict surgeon or a career, but you need to have that fine balance. But fundamentally, you cannot have everything in life, is what I always tell people. Anybody who says you can achieve everything in life, complete nonsense. In order for you to achieve something, you have to sacrifice something. And to achieve that, what you want to depends on how much you're willing to sacrifice.
So it brings us to the next proposition to you. Do you think that we are now at a point where the people you describe, both positively and negatively, need an accreditation process with a set syllabus and curriculum and a set of skills and a post-accreditation continuous professional development program to create a register of deployment-ready doctors and nurses? Is that where we are heading in terms of trying to bridge these chasms that the natural progression of medical care has taken us? Do we need a Royal College of Conflict Medicine or a board of conflict medicine where people in a parallel pathway through their career undergo didactic and practical training experiences and a logbook, and they commit to maintaining that logbook if they want to remain on the register?
Yeah, I think a great question. Basically, what you're saying is, do we need somewhere to validate governance? Make sure governance is being achieved so we can absolutely accredit it. I think the board, I think there are colleges, they come out willy-nilly, just after your name, and then they soon start to lose meaning. I think you only have things if your healthcare. So board, a continuous stream allows you accreditation, but also yeah, the best people to do this. And when I'm the best, actually want.
Have we lost Mansoor?
Yes, I think so. We'll just wait a few minutes until he reconnects.
Sorry, guys, back online. I just got kicked off internet.
Fantastic. So we were talking about the potential for a unified accreditation a process that leads to a register that allows the humanitarian sector to be able to ensure that people are not going there for the first time and maintains clinical governance in these austere environments. So if you want to take us through your thinking on that.
Yeah, I think the parallel stream is a really, really good idea. The problems I envisage with this is in an already burdened system, how do we actually run this parallel to it? And if we actually create a more conflict heavy system, then we lose the skill set individuals would get from an elective or an operative environment. And as we both know, after about 3 to 4 months of not operating or not doing a busy operating shift, your skills start to fade. And it's not just the operative skills, it's also the decision making which goes. So I find the decision making is the hardest thing to actually maintain. So I think this is going to be a very, very difficult one. But the only way to figure this out is try it. Absolutely try it and let's see what happens.
So in the military, how do you maintain people deployment ready? How do you ensure that people in between deployments still retain the skill sets that they had developed?
So a bit like the NGOs do, you do annual mandatory training and pre-deployment training, which is actually more getting to know the people and the teams that you're working with. I personally believe a course doesn't teach you how to do something. So when I run my trauma courses, I always say, this is your introduction into trauma. We are telling you the procedures, the techniques, the mindset, the theory behind how to do all of this, but it is now up to you to go ahead and maintain this and develop your skill sets further. So all of these things do is open the door into this avenue of training, into this way of thinking, but then it should be the individual's responsibility because as I say, I treat this very, very different. Conflict isn't something you wake up one morning and say, you know what, I fancy going to a war zone because it'll be really, really good for my CV. If you go with that mindset,
but people do.
That was going to come on to my further point. Trust me, they come out of the woodwork nowadays trying to do this kind of stuff. And there are some great, great individuals, and I'll mention them. You've got the likes of Professor Maynard, who's been doing this for decades, going to conflict zone under the radar. Nobody knew about it. He just went ahead and did it, and now vocalizing and standing out. So yeah, you have the solid folk, but trust me, the fraternity is very, very small. We know the attention grabbers. We know who people do this, but they're the kind of people you don't want as the front-facing individuals. It's like, you know what? I'll be honest with you. My personal view is when you give charity, okay, or when you give something to somebody who's asking for money, if you go around broadcasting it, okay, it really loses its value. The things that are done like this are best done quietly. And that way, I think once you have those kind of individuals coming into the frame, you start recruiting more and more like-minded individuals. Have I roundabout wordedly said what I should have said there then?
Absolutely. So we kind of circle back to the question, is there a place, and we will end on this question, is there a place for us to teach the basic fundamentals of war surgery to undergraduate medical students, the way we do with other surgical diseases?
I think if you think about it, I think it probably is towards the 5th year. And I personally think this will be my idea, and I think you've raised a fantastic point here, is most medical schools now do the exams earlier on, and they're left with a period of time. I think a 2-3-week module on, austere or conflict medicine, and I'll say medicine as a whole, which incorporates surgery. As you and I know well enough, if you are in a conflict zone, okay, yeah, you have stuff coming at you, gunshot wounds, blast and ballistics, but how much non-disease, non-battle injury do we get? How much diarrhea? How much poor sanitary? All this kind of stuff. Cholera, rife. I mean, all. So I think there is a huge place for that as a special module for 2 weeks, not to teach people, but to open their eyes into what the world is like. The world isn't just clean sanitation, etc. I mean, the vast majority of the world doesn't have access to potable clean water, never mind higher degrees. When I went across to Afghanistan, one of my mentoring jobs, and I always giggle at this, one of my senior officers said to me, Mansour, we need to train them to the standards of the UK. I was like, are you smoking weed? Seriously, this is one of the poorest countries in the world. If I can get them to do twice daily observations and do the basics of operative care to the ceiling level of what's present in that country. And I'll add another point onto this. What we really have to be very, very wary of, and I detest this, is, and I will say, a colonialist approach to medicine, where people turn up and say, we will teach you how to do medicine in your area. You've never walked in my shoes. You've never lived in this environment. Your medicine works for where you are. We have a completely different demographic, completely different resources, completely different life expectancy. How about we work in a partnership as opposed to you coming here and telling me how to do it? So I think there's a long way to do, but I think actually having a board or a faculty of conflict medicine would actually be really, really interesting for this. Very, very interesting, in fact. Gus, you're muted.
On that point, thank you so much for giving up some of your time in between your many travels. Hopefully, this is a conversation that we will continue to advocate for, and so that we are able to provide better care for those in need in these very difficult situations. Thank you so much, Mansour, for your time and for your expertise. And thank you, Tracy, for organizing this webinar. And thank you, everyone, for your attendance. Thank you.